You're seeing it now. So just before we begin,
Okay.
Thanks everyone for being here today. Hopefully you can hear me okay. If you have any issues, let me know. But my name is Rob Van Hoorn. I'm a program coordinator at Western University, and I'll be the moderator today. So just to review the rules for the session. So the presentations will be roughly 10 minutes with 5 minutes for questions, and then we'll move on promptly to the next speaker. So thank you everybody for, again, for being here, and I'll turn things over to Sherine.
So good morning, everyone. My name is Sherine Alsalhani, and today I'm presenting a study about the experiences of family physicians in caring for patients diagnosed with borderline personality disorder, BPD. The aim of the study was to explore the experiences in terms of the feelings and the caring attitudes of family physicians for patients diagnosed with BPD in the context of primary healthcare in London, Ontario. As an introduction, the feelings and attitudes of primary healthcare providers towards this group of patients have been described as negative. Patients with BPD were often labeled as difficult, manipulative, non-compliant, time-wasting, reckless, and attention-seeking. This has led to under-recognition of this disorder, where only 50% of those patients being recognized by their primary healthcare providers as having mental health problem, as well as receiving treatment. Evidence showed there is a number of factors influencing the feelings and attitudes of primary healthcare providers. This can be the physician's gender, the work settings, the rate of contact with patients with BPD, the physician's years of experience in family practice, as well as receiving specific training in BPD. Regarding research methods, this is a cross-sectional survey of the feelings and attitudes of family physicians working in community family health practices towards patients diagnosed with BPD. The study identified two groups of variables: independent variables in terms of gender, place of work, years in family medicine practice. The three of these are dichotomous variables, and the rate of contact with BPD in the form of an ordinal variable with three groups. On the other side, the outcome variables were in the form of 6 items feeling scale and 8 items caring attitude scale. We can see here in table 1 the outcome variables. Those ones originally developed by Cleary et al. 2002 in Australia, and it was adopted by the current study. Regarding data analysis, first we ran descriptive analysis on each of the 2 outcome scale to examine whether each of the scores were normally distributed or not. Then we ran bivariate data analysis, t-test, and one-way analysis of variance ANOVA, of course, to accommodate to the nature of the outcomes, dichotomous and ordinal. Second, a model of multiple linear regression was conducted for each of the 2 outcomes, the feeling scale and the caring attitude scale, trying to know the predictive ability of our independent outcome on the scores of the 2 scales. Finally, we ran secondary data analysis in the form of Spearman correlation coefficients and Pearson chi-square test. Study results showed we received a total of 58 completed questionnaires after we mailed 285, so the response rate was only 20%, unfortunately. Table 2 demonstrates the descriptive results of the 2 scales. We can see here that the scores were normally distributed on the feeling scale. However, the scores on the caring attitude scales violated normal distribution. T-test was run for dichotomous variables, gender, years in family medicine, and place of work, and there was no statistically significant relation between the dichotomous variables and either of the items on the feeling scale or the caring attitude scale. Figure 1 and Table 5 demonstrates the one-way analysis of variance to examine the impact of the rate of contact with BPD patients as an ordinal variable on the score of the feeling scale. As we can see here, a statistical significant relationship was found. As you can see, the sig here is the P was 0.001. However, the difference in the score between the 3 groups was weak. The same thing was found when we conducted one-way analysis of variance to predict the rate of contact of BPD patients on the score of the caring attitude scale. A statistically significant relationship was found. The P was 0.005. However, the score difference in between the 3 groups was also weak. Table 7 shows the results of multiple regression model 1. As you can see, the rate of contact with patients with BPD had a statistically significant predictive ability. The SIG here is 0.001, with each categorical increase in the rate of contact with patients with BPD, that is, with each less contact with patients with BPD, the model could predict a difference of 2.124 in the scores of the feelings. The same thing goes for the multiple regression model 2. The rate of contact with patients with BPD could also predict a statistically significant relation with the scores of the caring attitude. With each categorical increase, that is less contact with patients with BPD, the model could predict a difference of 2.406 on the scores of the caring attitude scale. Secondary data analysis in the form of correlation to examine the relationship between the rate of contact with BPD found statistically significant negative correlation with the preference of family physicians to avoid caring for BPD patients, for their feelings about being competent to care for BPD patients, and for belief that BPD is an illness that causes major distressing symptoms in the life of individuals with BPD. And there was also a statistically significant positive relationship with the level of satisfaction of family physicians in caring for this group of patients. Pearson chi-square between the dichotomous variables and each of the 8 items did not provide any significant relationship. The results of the current study, now regarding the discussion, the results of the current study are consistent with those of the Black et al. 2011 in terms of finding that Black et al. Also found that mental health clinicians who cared for larger numbers of patients diagnosed with BPD experienced more positive feelings towards this group of patients in terms of higher empathy and more optimism regarding the treatment. The current study, as well as Black et al., also found significant correlation between higher rates of contact with patients with BPD and the clinicians' belief in psychotherapy as a possible treatment, as well as their desire to receive further training in BPD management. The influence of the higher rate of contact with BPD on patients on experiencing more positive attitude can be explained that physicians with higher contact can have more experience, can have higher professional skills, and so they can build a higher trustful and continuous therapeutic relationship, can remove the stigmatization of BPD, and can have better interpretation of the social profile behind symptomatology, as well as better increase in the physician's self-awareness of their own feelings and attitudes. However, the reported inability to make positive changes in the lives of patients with BPD can also be explained in light of the massive challenges before the diagnosis and management, particularly in primary health care, the frequent presentation of BPD patients in acute crisis, the high comorbidity of BPD with other mental and chronic medical illnesses, the difficulty of maintaining and building a continuous therapeutic relationship given the abnormal behavior and dysregulated emotions experienced by patients with BPD, and finally, due to challenges related to healthcare systems in terms of short interview periods, long waiting lists to access psychiatric care, small number of family practices providing interprofessional collaborative care. The failure to maintain positive feelings can have many implications on practice, on education, as well as on healthcare policy. On practice, this can lead to unrecognition and underdiagnosis of BPD with deterioration of symptomatology. This can lead to excessive utilization of primary healthcare services, more visitations, more turnover between different primary healthcare providers, more visitations to emergency departments, and more consumption of psychotropic medications. Regarding the implications on education and training can increase the family physician's expertise of BPD diagnosis and management, and can help physicians develop the necessary self-awareness and self-monitoring of their emotions and behavior. Finally, the study found implications on healthcare policy. There is a great role of interprofessional and interorganizational collaboration in improving the care of patients with BPD. However, this requires the awareness of health policymakers to allocate more resources to health teams, to include mental health professionals, to improve referral systems to psychiatric care, to empower family physicians as the main patient advocate in the process of management and follow-up of BPD. Finally, the study experienced a number of limitations. First, the current study is a cross-sectional survey, so it lacks the longitudinal follow-up or a comparison group. Further research is needed to consider family health teams on large geographic scale. The response rate was less than 30%, and further research is needed to study the possibility for family physicians to change their behavior upon receiving more training or upon experience more collaboration with other healthcare professionals. Thank you very much.
Great. Thank you so much, Sherine, for that presentation. If I can just ask you to, while we're waiting for questions, if you can hand the host control back over to me, that would be great.
Absolutely.
Great. Thank you.
So I stopped sharing the, yeah.
Okay, perfect. Okay, is there any questions? We have a few minutes here for discussion. So either in the chat, the session Q&A, or please feel free to unmute and I can try to organize people as they come. So we have a question and two questions in the chat here. So from Lisa McCarthy, thank you for your talk. What are your next steps now?
Well, actually, thank you, Lisa. My next step is going to be part of my PhD. This research was part of my master degree. In my PhD, I'm looking forward to develop an evaluative research regarding a possible training module for residents of family medicine regarding personality disorders and particularly BPD. That's my next steps. And I'm also looking forward to conduct qualitative research. I want to interview family physicians and know their ideas and their experiences with patients with BPD, and hopefully we can, I don't want to say develop a theory, but we can have a better understanding about this topic, especially in primary healthcare. I want to emphasize here on the importance of interprofessional collaboration. I really would like to explore more about collaborating healthcare workers like psychologists and social workers in family health teams and see this impact on mental health in primary healthcare settings. And then there's another question.
Yeah, so
yes, I agree. I agree that family health teams can be, I agree that family health teams is a very good model of dealing with the multiple morbidity associated with personality disorders and other mental disorders. But I have to emphasize here that the family physician should remain the main advocate. So family health teams is a great idea. Interprofessional collaboration is mandatory, but the family physician should still carry the main responsibility of advocating patients through the healthcare system.
Great.
Thank you very much.
Sherine, can I just get you to click on Kadesha James's name and give her the host control?
Absolutely. Okay, 1 second. So, Kadesha, yes. Is it asked to unmute?
Yep, I just asked to unmute. You can hear me?
Yes, great, thank you. So, Kadesha, while you're sharing your screen there with your presentation, there we go.
I will do that now.
Okay, so I'll just introduce you now. So our next speaker is Kadesha James from the University of Toronto, and she'll be presenting on understanding medication self-management in community-dwelling adults with chronic medication experience, an exploratory concept mapping study. So Kadesha, I'll pass it over to you. So just a reminder, we have 10 minutes for presentation and 5 for discussion.
Thank you so much. My slides, you can see them?
Yeah, I can see them well.
Great, thank you so much. Okay, so good morning, everyone. My name is Kadesha James. Most people call me Kay. I'm a second-year Master of Science student in Pharmaceutical Sciences for U of T, and I'm really happy to be here on behalf of my team to present our study in progress to you all. And as I was nicely introduced, I'm going to be delving into how we are working on understanding medication self-management through the method of concept mapping. And so I have no conflicts of interest to disclose, and the project is funded by the Faculty of Pharmacy. And so why are we pursuing the topic of medication self-management? Well, a significant number of people worldwide rely on medications to manage their health. More people than before have access to essential medicines, and retail spending on pharmaceuticals has shown a 35-year pattern of growth in Western nations. And further, many Canadians take both prescription and non-prescription medications on a regular basis. And so, given that such a significant proportion of the population takes medications, it's really important to understand their experiences with medications in order to address their care needs. And so, our goal is to contribute to the understanding of medication self-management. And by self-management, we mean an individual's ability to navigate the wide variety of lifestyle factors and changes, these could be physical, social, or cognitive, associated with taking their medications. And so when we look to the literature, we try to see what frameworks we currently have at our disposal to understand medication self-management from a theoretical standpoint. And so these resources can mainly be divided into two types. We have chronic disease self-management on the one hand and medication adherence on the other. But there are pitfalls with both. So on one side, we have chronic disease self-management literature, which tends to address the physical and psychosocial factors related to dealing with chronic conditions. However, the role of medication in disease management and the unique challenges that it presents tend to be minimally explored. And then on the other side, we have medication adherence literature. And so while medication-centered, these frameworks tend to focus on how behavior conforms to recommendations from health professionals, but medication taking is not often explored through a holistic self-management lens. And so faced with this puzzle, we're working to contribute to constructing this missing piece in the middle, where we can look at understanding medication management from a holistic self-management lens. And so our research question was, what can persons with chronic medication experience contribute to our understanding of medication self-management? And we had three main objectives: to figure out what matters most to individuals, to see what factors they deem most important and feasible, and to see how those perceptions of what is most important and feasible varied by personal characteristics, such as age and gender. And so to answer the questions, we're using the method of concept mapping. Concept mapping is a mixed methods, qualitative, quantitative, participatory action research method that consists of three distinct stages. Stage one is brainstorming, and this is where participants in a group discussion generated responses to a main focal question. And our question was, what matters to you about medications in your everyday life? And so once all the brainstorming groups were completed, we consolidated the responses down into a manageable number for stage two, which is sorting and rating. Sorting and rating is an individual process where each participant was asked to sort the statements into piles based on how they thought they were similar to one another. We also asked them to rate each statement based on how important they thought it was and how feasible. And then after that, we went through a process of map creation where we made a visual representation of the statements based on the sorting data. And then we held our last group discussion session in stage three mapping, where a subset of participants had the opportunity to view these visual maps, edit them, and reach a consensus on one final representation of the statements and how they related. And so I'm going to tell you a little bit more about what a concept map actually looked like and tell you how they're created. And so these two images are from a methods paper for illustrative purposes. And so on the left hand, I have a point map. Each numbered point equals one statement. And the best way to understand how this is created is to imagine that you were trying to draw a map of the province of Ontario. And you knew the relative distances in between cities, but you didn't actually know what Ontario looked like. You could use those relative distances to draw your best guess of the province. And that's a similar analogous process to what the software is doing. So in our case, the relative distances in between statements are determined based on how often statements were sorted together by participants. So two statements that were often sorted together are close together, and statements that were not often sorted together are farther apart. And that's how you get the point map. The cluster map draws boundaries around groups of statements to create clusters. And as a result, each cluster can be thought of as a group comprised of statements of a similar topic. And so we've only recently wrapped up our own data collection, and we still have analysis to do on our final maps and cluster maps. And so today I'm going to share some results of the brainstorming stage with you. So who were our participants? We had 63 people participate in brainstorming. The majority of them were younger and female. The majority of them had been taking medications on a daily basis for a time period of at least 3 years or more. Most of them took 1 to 2 medications daily, and most of them had either 1 or 2 chronic conditions, but a significant proportion of them had no chronic medical conditions as well. And so our participants were really engaged in our group discussions, and they were able to generate a total of 1,044 statements in response to our question. And so how did we consolidate down 1,044 statements into something manageable for sorting and rating? So this is a simplified example of the schema from our statement consolidation process, which we use Excel for. In the leftmost column are 2 original statements from participants as recorded by a team member during the session. And so our first step was to determine, do the statements answer the focal question? If they did, we edited them slightly for clarity, and then if not, they were eliminated. Then we went through the full list of statements and added a small tag to each one that captured the gist of it in a few words. So for this one, the tag could be easy to take. Then we sorted the statements by the tags, went through each one, and highlighted similar statements for consolidation. And so after 2 rounds of that consolidation process, we were able to boil down the list into 94. And so what were these statements that participants came up with? So this is some examples of the themes. It's not an exhaustive list, but gives you an idea of the nature of the discussions that we had. So starting at the top, ease of use was important. Statements related to properties of the medication itself, such as is it pain-free administration, is formulation easy to take, and also the convenience of the dosing schedule. Going clockwise, medication effectiveness was important. People were concerned that the medication worked, but also had minimal side effects. Decision-making and autonomy, having adequate information to make the decisions and the right people to consult. Effective communication with health professionals, receiving social support and mitigating stigma, and being able to integrate taking medications into their daily routines. So these are some of the priorities identified by our participants about what mattered to them. And so I said the study is still in progress. So our next steps are 1, to stratify the results of the rating task by participant characteristics to explore possible differences between genders, age groups, people taking different numbers of medications, etc. And then to analyze the final concept maps, the point and cluster maps, and look at how participants modified their map in the final group discussion session. And so even though this project is ongoing, we've just recently wrapped up the data collection, there are some key messages that I do want to leave you with. And those are that our participants were so actively engaged during our online group discussions. They shared so openly, and it really showed us that taking medications and their experiences around those were such a big part of their daily lives. And even though our population was mostly younger and took fewer medications and had fewer chronic medical conditions than what is typically highlighted in medication adherence and chronic disease literature, they still had diverse priorities and experiences to share. And so it showed us that an important gap in the literature is being addressed as well through our study population. And lastly, our preliminary results suggest that we really need to move beyond traditional ideas of adherence and towards a more holistic approach when thinking about people's experiences taking medications. And our results so far suggest that if we really want to provide person-centered medication education, prescribing, and counseling, health professionals need to understand lived experiences with medication through a holistic self-management lens. And so a big thank you to the entirety of the research team and my participants, of course, for their deep engagement. And I'd be glad to open up the discussion. Thanks.
Great. Thank you so much, Kay, for that interesting presentation and great slides. The slide with the puzzle piece was great. I just have a quick question off the bat, and then I can turn it over to others that might have questions. I'm assuming that this study started prior to COVID hitting us, but how has that impacted the way that you've been you know, running these participation groups, these discussion groups to gather information, and have you had to kind of pivot at all and include any other type of you know, interactions or anything like that to be able to accomplish your goals for this study?
Yeah, great question. And so I think a lot of researchers can relate that at the beginning of the COVID pandemic, we had to completely kind of flip our methods around and navigate to hosting these group discussions online. So originally they were planned for in person, but we had to pivot and use Zoom instead. And originally we were a little bit concerned about, you know, will engagement be the same as in person content mapping discussions groups? But we found that using Zoom was actually quite effective. People were still very engaged in the discussion process, whether they joined by video or not. We got really good discussions. And so, yeah, we were able to pivot to Zoom. Of course, there is the barrier of the, you know, you must have a device and have a stable internet connection now to participate in our study, whereas in person, that would not have been a barrier before. But overall, we were really happy with how the online recruitment process and using Zoom to facilitate the groups went. It was a new experience for us doing content mapping completely online like this, but yeah, it's been a really successful experience so far.
Okay, great. That's great to hear. Okay, there's a question in the chat from Leslie Meredith. How do you think the lower age range of your sample may have impacted the results?
That is a great question. And so, of course, we hoped for a little bit more diversity originally in terms of age. But we were really surprised to see that even though most of the participants were younger, a lot of them were living with complex medical conditions and were taking, even though it might have been one or two medications, a lot of them were taking them for a significant period of time. And so I do think that, you know, just based on patterns of how it goes in the population, that we did end up with a cohort that took typically less medications and had less chronic conditions than we would have had if we were able to get a wider age range. But thankfully, they really were engaged, and they showed us that even though they may not have been taking the whole handful of medications every single day, they were, the one they did take, it was a big part of their lives. And so, yeah, we did originally hope for a little bit more spread in the age, but we're still able to get great discussions and data.
Okay, excellent. We have another minute or two here. If there's any other questions, I don't see any in the chat yet, but if there's anybody that wants to jump on with their microphone, happy to have you ask that way as well. Okay, Kay, well, thank you so much for your presentation. And we're going to keep passing the baton along. So, Kay, if I can just ask you to hand over the host control to Annalise Mathers, that would be great. So just hover over her name and you should see the option there to make her the host.
Sure, I will do that. I see this is guest. I'm not seeing
that. Okay, so maybe if you hover over my name, perhaps you might have the option to make myself the host again.
Okay. I'm here in the embedded Zoom on the Who site, and when I hover over names, no options pop up. So
okay, all right. I'll see.
It looks like Sherine is maybe still the host on.
Oh, okay.
Sorry, this is Annalise, but on my end, it kind of looks like Sherine is the official host.
Oh, okay. Yeah, I see that.
To her name.
So Sherine, actually, if you can hover over my name and provide me with the host.
Yes,
yeah,
I was surprised why I'm. Okay, there we go.
Sorry, we're all pulling together here to make this work. In the meantime, Annalise, are you able to share your screen and get your presentation loaded? It may not matter about the host. I'm not quite sure. Okay, you are.
People can see that?
Yeah, perfect. Okay, well, thank you, Kay, again for your presentation, and I'm going to introduce Annalise now. So Annalise is from the University of Toronto, and she's presenting on the implementation of the appointment-based model in Canadian community pharmacies. So Annalise, I'll turn it over to you.
Thanks so much, Rob. So as Rob just mentioned, this study was done with our research team at the University of Toronto, the Studium Faculty of Pharmacy, and we also worked very closely with Whole Health Pharmacy Partners, which is an independent pharmacy banner, community pharmacy banner located mostly in Ontario, but also across Canada. So delighted to be here today to share some of our work. I'm going to whip through this, follows the very traditional outline of most research presentations today. And jumping right into our presentation. So as we know, community pharmacy is traditionally quite reactive in nature, and it typically waits for patients to request medication refills. So in this current model, patients request their prescription refills on an unaligned schedule. So this means that previous studies have documented that this can decrease adherence as well as pharmacy efficiency. And ultimately, this can result in longer wait times as well as limited time for pharmacists to provide clinical care. The appointment-based model, or the ABM, shifts current practice into a proactive model of care where the pharmacy team is able to coordinate all prescription refills on one synchronized day each month. This ultimately provides an opportunity for the pharmacist to have regularly scheduled appointments with patients. And during these appointments, the pharmacist is able to provide clinical services such as medication reviews and optimization. So this may look like deprescribing. They're also able to perform monitoring and screening. So for example, blood pressure monitoring. And they also have the opportunity to provide adult immunizations, for example, the flu shot. So the ability of the ABM interaction can really address a lot of patient medication needs from a holistic perspective. So to date, the ABM has been shown to increase adherence, enhance medication safety, as well as patient satisfaction. And it's also been shown to create a better relationship between the patient and pharmacy team. Over the last decade, implementation and uptake of the appointment-based model has most significantly grown in the United States, and it's estimated that the ABM is currently being used in about 10% of pharmacies across the United States. So though there has been some uptake of the appointment-based model among Canadian pharmacies, there's been no data published on the impact of the ABM in the Canadian pharmacy setting, and particularly in Ontario, where our study took place. So the objective of our study was to be the first to evaluate the impact of the ABM on medication refills, medication adherence, and clinical services provided by pharmacists within independent community pharmacies in Canada. And then our secondary objective was that our study also aimed to identify key characteristics of patient populations that have benefited from implementation of the appointment-based model. So Whole Health Pharmacy Partners is a pharmacy banner of independent community pharmacies located across Canada. And as I mentioned, there's a predominant presence in Ontario. So in September 2017, select Whole Health locations began to implement the appointment-based model in their pharmacies. In October of 2018, a convenience sample of 3 pharmacies were selected for retrospective data collection and analysis. So pharmacy data was extracted from Choe, which was the pharmacy management software used at the 3 locations that were selected. And our inclusion criteria for the study was that a patient must have filled at least 1 standing chronic medication, as well as consented to the appointment-based model. And then our exclusion criteria were if a patient had changed pharmacy locations, had passed away or had only received the medication synchronization portion. So refill data was collected for patients on at least one continuous medication for 6 months pre-post and 12 months pre-post ABM implementation. And this was also used for the adherence analysis. So we used 4 different time points, 12 months and 6 months before implementation of the appointment-based model, and 6 months and 12 months after implementation of the appointment-based model. And then for the demographic and clinical service information, descriptive statistics and frequencies were analyzed using StataCorp software. And finally, consent was received from both participants participating in the study at whole health pharmacy locations, and our study was approved by the University of Toronto's Research Ethics Board. So getting into our research findings, our study included analysis from 3 pharmacies and a total of 131 patients. So approximately half of the patients were female. The mean age of the patients was 71 years. And these patients were highly medically complex. So we found that they were prescribed an average of 7 medications. And so we then conducted an analysis to determine how many of these patients experienced polypharmacy, which is the use of 5 or more medications. That's the definition we used. And we found that 78% of patients experienced polypharmacy, so quite a high number. We also looked into the medical conditions that a patient experienced, and the most common ones were hypertension, either prevention or treatment of hypertension, dyslipidemia, again, prevention or treatment, as well as GERD. So then turning to the medication refills, our results showed that the ABM resulted in patients visiting the pharmacy less often to obtain their dispensed prescriptions, but that they had the same or more numbers of prescription refills. So going into that a little bit further, patients had a significant reduction in the mean number of distinct refill dates, yet a significant increase in the mean number of refills. And this was seen at both the 6-month pre-post mark as well as the 12-month pre-post mark of implementation of the appointment-based model. In terms of clinical services, we focus mostly on meds checks. So meds checks are a medication review service that are provided by pharmacists for individuals in Ontario meeting certain criteria. So for example, 3 or more prescription medications for chronic conditions. So with these clinical services, we found that 57% of patients received 1 or more meds checks on the day of enrollment in the ABM program or after their enrollment in the ABM program. So during these meds checks, we were also able to look at kind of what was identified during the actual meds check appointment. And we took a look at the DTPs or drug therapy problems that resulted from those. So the top DTP classes that emerged were that a patient needs additional drug therapy, that there's a therapeutic duplication, and so the prescribed drug may not be necessary, and then adverse drug reactions. So those were the top 3 classes of DTPs that were identified through meds checks. And then turning to adherence. So for adherence, we used a definition for proportion of days covered. So the number of days in the period covered with a medication divided by the number of the days in the period and then multiplied by 100%. So our preliminary results show that patients had high baseline adherence to begin with. So over an 80% threshold is considered high baseline adherence. And this was across medication classes. So statins, oral antihyperglycemics, and antihypertensives were the classes that we looked at. So after our analysis, we found that the ABM program preserved the high adherence across all medication classes studied, and it also demonstrated a statistically significant increase in adherence to statin therapy, ACE inhibitors or ARBs, and thiazide diuretics, both 6 months and 12 months after implementation of the ABM program. So turning to discussion, our study is the first to evaluate the ABM program within the context of the Canadian healthcare system. We found that in our study, the ABM was implemented for medically complex patients who were experiencing polypharmacy, and this may result in it. Our results suggest that this may result in improved medication refills and medication adherence. We also found that the ABM may promote improvements in patient flow to the pharmacy, making this process more efficient, which may in turn reduce pharmacy workload and operating costs. So we also found that the ABM was associated with clinical service uptake and DTP detection by the pharmacist. So this may also demonstrate that the ABM can serve as an opportunity to enhance patient medication safety. One of the limitations of our study was that it was a fairly small sample size of 3 community pharmacies, and our results are only representative of Ontario. So in conclusion, our findings support broader adoption of the appointment-based model across community pharmacies in Canada. Next steps on our front include evaluating patient and pharmacy provider satisfaction with the ABM, so looking at how people's experience went with implementation of the program, as well as using the results of our study to inform the design of a prospective trial to more rigorously assess the impacts of the ABM on adherence and medication refills over time. So in conclusion, I'd just like to thank our research team. I have the authors listed at the top, as well as the many University of Toronto and University of Waterloo pharmacy students who have supported this project in terms of data validation and analysis. There was a lot of data to sift through. And we'd also like to thank Whole Health Pharmacy Partners, as well as the Canadian Foundation for Pharmacy, for funding this research. So that is everything from me. Happy to answer any questions now.
Great, thank you so much, Annalise. All right, do we have any questions here? Okay, this question is from Leslie Meredith. Who are the providers you will talk to about satisfaction? In this program, are family physicians contacted before change of medications?
Yeah, so that's a really good question. Primarily, what we are considering and what most of the literature is focused on to date is assessing patient satisfaction, definitely, but primarily pharmacist and pharmacy staff perspective, so pharmacy technicians or pharmacy assistants. That's what most research is focused on, and that's what we would hope to do in studies moving forward with Whole Health. In terms of family physicians, I'm not sure the process that has been followed directly with that. I think it's difficult in some cases because there are different family physicians associated with different patients. So I can't speak as much to consulting physicians on satisfaction, but I think moving forward, this could really be something important to assess, particularly in environments where pharmacists are co-located with physicians, and as this model perhaps takes greater hold across Canada.
Great. Sherine, did you have a question? No. Okay. I may have missed this in the intro, but how are the patients selected for this process? Is it patient driven? Like, do they request this, or could we get to a point where because you mentioned there was like certain factors that typically patients had in order to be part of this. Could this be EMR driven as well, where you're finding people that have polypharmacy, have multiple morbidity potentially, and kind of select them to be part of this program?
Yeah, that's a fantastic question. So the way that things worked at Whole Health were just any patient that came into the pharmacy to pick up a medication refill was given a brief overview of what the appointment-based model is, and then they had the opportunity to either consent at that appointment or to make a subsequent appointment to have a consultation with the pharmacist. So I would consider it a fairly open enrollment. We weren't targeting specific patients with this, but I think given our results, it's very surprising to me how it's surprising, but also encouraging that a lot of patients that were enrolled were on a significant number of medications, had a significant number of medical conditions, and could really benefit from having a set time to sit down with the pharmacist and perhaps have a med check or just have a good medication review. So I think moving forward, this is definitely a program that could actively target patients who are on a significant number of medications. That would be fairly easy to identify through Kroll, and kind of make a short list of patients to approach who might receive the most benefit from this program. But I think our results are encouraging in the sense that it seems to have kind of a wide benefit for a large number of patients, at least visiting these pharmacies. So yeah, really good question. Thanks, Rob.
Yeah, that's interesting. It looks like there's some lots of room for next steps there in terms of where to go next.
Yeah.
Yeah. Okay, we got maybe 30 more seconds if there's anybody that wants to ask a question. Okay, well, thank you so much, Annalise, for that presentation.
Great, thank you.
Okay, next I'm going to ask for our final presentation, Albert Choe will be presenting on behalf of his research team, which has Eric Liu and Michelle Greiver as part of it, representing the North York Family Health team. And so Albert, if you want to share your screen.
Yeah, of course.
We'll get your presentation loaded there.
Can everyone see my screen and hear me okay?
Yeah, I can hear you great and can see your screen. So I'll just, people can read the topic there, but Albert will be presenting on sedative-hypnotic deprescribing in a team-based primary care practice. And so I hand it over to you, Albert. Thank you.
Sounds good. Thank you so much. Good morning, everyone. My name is Albert. I'm a medical student at Western University, and I work with the North York Family Health team on this project, Sedative-Hypnotic Deprescribing in a team-based primary care practice. We have some really good data for you as well as some good clinical implications, so I'm so glad you tuned into the talk. The first thing I want to emphasize is that deprescribing sedative hypnotics is such an important patient safety initiative. And as I'm sure many of you know, there's such a high prevalence of chronic benzodiazepine and Z drugs such as sulbaclone and zolpidem use in Ontario in older adults. And this is associated with significant risks, including an increased risk of falls, adverse cognitive events, as well as an increased risk of hospital admission after a motor vehicle accident. So it's also important to note that for patients with chronic insomnia, long-term use of sedative hypnotics is actually not indicated. And it's been found that long-term use of sedative hypnotics starts to decline in efficacy after 4 weeks. And there was actually a study performed that found that an educational intervention based on a brochure was able to help patients taper at 6 months follow-up. And this led to a 27% rate of complete abstinence, which was fantastic to see. Now, the North York Family Health team has already been trying to deprescribe a lot of their patients from sedative hypnotics. One of the strategies that they're implementing is implementing CBTI, or cognitive behavioral therapy for insomnia. And that is an evidence-based first-line intervention for chronic insomnia. And it includes using a sleep diary to track your sleep, sleep restriction, stimulus control, all of these things, which are basically aiming to teach your patient how to sleep again. And this has also been studied and its impact on deprescribing. And there was a Canadian randomized trial actually that showed that the inclusion of CBTI in the deprescribing program can lead to a 77% rate of complete abstinence versus 38% without CBTI. Now, this was great data, except one of the issues that we had with it was that it had low participation rates and very strict inclusion criteria. So in other words, they only allowed patients who had chronic insomnia and no patients with any psychiatric or other kind of medical comorbidities. And we didn't really feel like that really reflected the patient population that was using benzodiazepines and Z drugs chronically. So we had two main research questions on our program. The first one being, did our deprescribing program actually lead to tapering or complete abstinence in a real-world clinical setting perspective? And the second one being, did the inclusion of CBTI improve the success rate? So these are our methods. On the left, we're going to start there. And so this is our study design. We did a retrospective chart review on the electronic medical records. This was within the North York Family Health Team, which is includes a wide variety of different kinds of family physicians and interprofessional healthcare providers. And we collected data between February 2016 to June 2019. And as you can see at the bottom left there, we had a very wide patient inclusion criteria. Basically, patients just needed to be on chronic benzodiazepine or Z drug use to be referred for the program. As you can see on the right side, there were two different kinds of intervention groups that we had. At the top, there was just the deprescribing program alone, where patients would be referred from family physicians to our pharmacists on team. And these pharmacists would meet with all of the patients in person or either by phone, and they would meet with them regularly, and they would go through with them a deprescribing schedule, make any adjustments to their dosing or medications, and of course, give them an education on the risks of sedative hypnotics and also help them practice good sleep hygiene. Now, patients also had the choice of enrolling in CBTI on top of the deprescribing program, and this was conducted by pharmacists as well, or social workers who were trained in CBTI, and this was performed one-on-one or through small group sessions as well. And it included all the things you would get from the deprescribing program, as well as all of the CBTI elements that I mentioned before. So, as I said before, we had a very wide general population that we studied. We collected a lot of baseline data. On the left, you can see kind of the main thing I want you to get is that we collected data on their baseline sedative hypnotic medications. So the kind they were using, whether it was benzodiazepine or Z drug, what the dosage was at baseline and how frequently they were using it. So were they using it every day or were they using it as needed whenever they wanted? And of course, at the bottom, you can see a lot of our patients also had mood disorders that they were wrestling with or other kinds of comorbid psychiatric conditions, which really broadened our study population into a real-world clinical practice. Our outcome measures on the right side, you can see our primary outcome measure was the percentage of patients who achieved complete abstinence or a greater than 50% dose reduction. And that's kind of how we define success in our study. And our secondary outcomes were the pace at which they were able to deprescribe, the number of patient encounters associated with the deprescribing program, as well as the impact on sleep that the deprescribing program had as measured through the Insomnia Severity Index score. So this is kind of our referral flowchart that you can see here. We were very encouraged to see that we had such a high participation rate following referral. As you can see in that red box there, 92% of patients enrolled after being referred to the program. And going down from there, you can see that many of them opted to be in the deprescribing program without CBTI, which is fine and expected, but we still had a good amount of participation in the CBTI group as well. So this is our primary outcome. You can see that we were very encouraged to see that 65% of the patients in the study, you can see at the bottom right, were able to successfully taper from sedative hypnotics. So we were very encouraged by that. You can also see the comparison that we have between patients without CBTI and with CBTI. There was no statistical difference between these two groups, which is kind of unfortunate. We were also able to see the pace at which they were able to deprescribe, which is 7.3% of the original dosage per week at the bottom there. And there's the average length of the process as well, which is 21 weeks. Now, please keep in mind this can vary widely depending on the individual. And one of the lessons that we learned from this was that every patient deprescribes at their own pace. So we also wanted to see if specific patient characteristics had an impact on whether or not they were more likely to deprescribe. And a lot of physicians and patients too are under the assumption that said drugs are less prone to dependence as benzodiazepines. However, what we found in this study was that actually might not be so true, and both patient groups had an equal difficulty deprescribing or equal success rate at deprescribing. We also wanted to see in the green box there if patients using sedative hypnotics intermittently were more likely to deprescribe, and that was not statistically significant either. So a couple interesting findings that we found that we're basically aiming to see what deprescribing looks like in a real world practice. So this talk would not be complete without mentioning that CBTI did lead to more patient encounters as opposed to deprescribing without CBTI. So you can see very clearly that deprescribing with CBTI led to almost 11 patient encounters on average per patient, whereas if they didn't get CBTI, they still only had 6 encounters. But the caveat to this was that for patients who are in the CBTI group, many of them did experience an improvement in sleep quality as measured by the ISI. And we measured ISI before and after CBTI, and you can see at the bottom there, 73% of them had an improvement. So these are the few key takeaway points that I have for you. Our program was, in our perspective, very successful. We were very happy to see that so many of them tapered or stopped taking sedative hypnotics totally. And the use of sedative hypnotics didn't actually, or the use of CBTI did not lead to a significantly greater chance of successful tapering. And the important caveat to that is that this is a real world clinical setting. And also the total number of patient encounters was greater with CBTI. But of course, and you always want to consider CBTI for patients who really have a hard time sleeping. Now, just to go through a few limitations, we did have a selection bias, so patients who were enrolled in the CBTI group may have reflected a proportion of patients who were perceived as having more sleep issues. We also had a limited sample size, and we didn't actually measure ISI before and after the program for patients who are just in the deprescribing group. So we feel like this may have underemphasized the impact that CBTI had on patients' sleep quality. And just the final thing, I just want to leave a few resources for you in case you're trying to implement this in your own practice. There are fantastic guidelines and images and figures available for you and your patients. And I just want to thank the North York Family Health team for such a fantastic project and program. And thank you so much for listening to my talk.
Thank you so much, Albert. That was great. Okay, so I'm going to open it up to questions now, and I see that there is some questions in the chat. So was CBTI provided by the same person each time? Just wondering about the standardization of treatment across participants. And that question is from Leslie Meredith.
Yeah, thank you so much, Leslie, for the question. That's a great question. So I'm not sure if you saw before, but CBTI was administered either by pharmacists, clinical pharmacists, or social workers. All of them were trained in CBTI. There was even an internal audit that tried to see the differences in ISI for people who were under the pharmacists or the social workers, and the mean change in ISI was the same across specialties. But on your question specifically, each person was followed by either the same pharmacist or the same social worker. Pharmacists would do the deprescribing at the same time as they would do the CBTI, whereas social workers, they would do the CBTI separately from the deprescribing, and they did either one-on-one sessions or small group sessions as well.
thought it was interesting that the RCT you mentioned at the beginning, your study, both had 77% success rate with the CBTI.
With CBTI, yeah. Yeah, that's really fantastic to see, and that's kind of what was so inspiring about implementing CBTI in our own practice, for sure.
So there's another question here. With a larger sample size, that would be an interesting sub-study in terms of different providers. So that was a follow-up question from Leslie.
Right, of course. It definitely, yeah, it definitely would be interesting. I know CBTI is not just done by community or clinical pharmacists or social workers, but by psychiatrists as well, and clinical psychologists. So it's interesting to see kind of what resources we can pull, and it really emphasizes how important it is to be a multidisciplinary clinic and to be able to use the resources that you have. And I think it's so important to be able to get both teams working on it, because you really get value from different kinds of healthcare providers.
Great. Okay, so we have about another minute for any questions, if there's anything. If anybody wants to jump on with their mic, that would be okay. Okay, well, hearing none, I guess we will wrap up our session. Albert, thank you so much for that great presentation. And thank you, everyone. I want to thank all of our presenters for sharing your great work, and lots of really interesting stuff going on, and lots to be excited about, you know, things coming our way. So thank you, everybody, for joining in on this session, and enjoy the rest of the Trillium conference.